HSM 801, page 541, the Nigerian health system. Expected learning outcome. This activity is intended for clinicians, administrators, and health managers. The goal of this activity is to use the multimodal learning strategies to give an insight to public health practitioners on the Nigerian health system. Upon completion of this activity, participants will be able to 1. Understand the meaning of health system. 2. Appreciate some salient background characteristics of Nigeria. 3. Understand the historical development of formal health care in Nigeria. 4. Know the current state of the Nigerian health system and the health status of Nigeria. 5. Understand how services are provided under the national health system. 6. Explore the various policy options available for the advancement of the Nigerian health system. Definitions. Health system include all the institutions, activities, and funds whose primary purpose is to promote, restore, or maintain health. Roeman 1991 defined health system as a combination of resources, organization, financing, and management that culminates in the delivery of health services to the population. Important components of the health system include 1. Governance, 2. Resource generation, 3. Provision, and 4. Financing. Health is the defining objective for the health system. This means making the health status of the entire population as good as possible over people's whole life cycle, taking account of both premature mortality and disability. Healthcare services provided to individuals or communities by agents of the health services or professions to promote, maintain, monitor, or restore health. It is not limited to medical care, but extends to include health-related self-care. Formal care, care provided by trained, paid professionals, usually in a formal setting. Lay care, care provided by lay people who have received no formal training and are not paid. It includes self-care, care by relatives, friends, and self-help groups. Self-help groups, groups of unpaid self-taught people that offer solutions to health problems in a lay setting based on mutual support between persons experiencing similar conditions. Investments. In finance, investment is simply putting money into a project with the expectation of gain over a long time. In economics, investment is related to saving or deferred consumption. All forms of investment involve some form of risk, including inflation risk. Two important things to consider in investments are the returns on investment and the relative risk of the investment. In an efficient market, all investments with equal risk should have the same expected rate of return. Health coverage. Universal health coverage or social health protection. Universal coverage is defined as ensuring that all people have access to needed health services, that is prevention, promotion, treatment, and rehabilitation, without facing financial ruin because of the need to pay for them. Background. Nigeria is a geographical, religious, and culturally diverse country in West Africa. There is a double burden of diseases caused by the rise in non-communicable diseases and accidents in a milieu of communicable diseases. There is communicable disease and non-communicable disease and accidents rise in a milieu of communicable diseases. Health care is provided through formal and traditional practices, with the formal practice comprising both publicly and privately managed facilities. Public health services are provided through primary, secondary, and tertiary health facilities, which are organized under the local, state, and federal government respectively. Despite higher health inputs, the Nigerian healthcare system is still performing below the Ghanaian and indeed the WHO Afro region. The involvement of patients in the design and management of health services is still rudimentary. Enhanced participation of patients in healthcare can lead to improved quality of health delivery in Nigeria. Background characteristics. Geography. Nigeria is in West Africa and shares land borders with Republic of Benin in the west, Chad and Cameroon in the east, and Niger in the north. Nigeria is constitutionally a federal republic, a republic comprising 36 states and a federal capital territory, and within each of these states are the local government councils. In all, 774 local government councils make up the country's diverse geographic, linguistic, ethnic, and religious constituencies. The emergence of 6 geopolitical zones, 3 in each in the north and southern regions in recent times, was the basis of the major divisions recognized in modern Nigeria. These geopolitical zones are comprised of 5 southeast to 7 states northwest, and they reflect greater homogeneity in culture, religion, and language of the people. So page 548 is a map showing the 6 geopolitical zones and the states in each geopolitical zone. So we have the northeast, northwest, north central, southeast, south, southwest. So it's to know the different states within each geographic region. Okay, so background characteristics, political and economic. Nigeria had several years of military rule since it gained independence in 1960 from the British. This era was characterized by poor economic management and a decline in performance of public institutions. Civilian administrations had not fared better, as they are endlessly confronted with high political demands from the diverse ethnic and religious groups. The poor ability of civilian administrations to manage these demands has ostensibly given opportunities for the frequent military incursions into governance and public administration in the past. Further implications of the unstable political environment in Nigeria is its effect on strategic planning and investment, especially in health and social programs, as critical decisions are often political and not evidence-based. The choice of political leadership is often driven by the insular compass of ethnicity, linguistics, and religion, and this had reinforced the fiscal discordance and left no clear social contract between the government and the people. Nigeria has abundant natural and human resources, but the economy is still heavily dependent on natural resources, especially crude oil. Rivers State at a glance. As of 19th October 2022, World Population Review. Rivers population 7,034,973. That's 2019. Ranks 7th in Nigeria. Area 11,077. Should be square kilometers. So ranks 26th in Nigeria. Population density kilometer square 468. That is 468 per kilometer square. Ranks 5th in Nigeria. GDP 21 billion dollars. 21,073,000,000 US dollars. Ranks 2nd in Nigeria. Local government areas 23. Urbanized population 52%. Training institutions for health workers 7. Primary health facilities 342. Secondary health facilities 21. Tertiary health facilities 4. Health governance structure. We have the Ministry of Health. Then you have the Primary Healthcare Management Board. You have Hospitals Management Board. Then you have the Board of Teaching Hospitals. Chaotic state of the Nigerian health system. About 125,000 nurses registered in Nigeria now. Number of Nigerian nurses in the UK increased by 25% in the last 6 months. About 57,000 nurses have left Nigeria in the last 5 years now. That is National Association of Nurses and Midwives. So we see that nationwide strike, resident doctors, ASU national strike. So that's page 551. Social demography and health. As of 16 July 2023 Worldometer, Nigerian population is 225,039,854. Population density is equal to 246 per kilometer square. Rank 70 in the world by population. World share of population 2.78. Median age 17.2 years. Urbanized population 53.9%. Life expectancy at birth 53.87 years. About 3% of population are above the age of 65 years. The epidemiological pattern of disease shows a double burden of disease. Infants and under 5 mortality are 69 and 128 per 1,000 live births. Only 38% of births are supervised by skilled birth attendants. Only 25.4% of children under 1 year of age are fully immunized. Politics, economy, and social demographic profile. Nigeria has several years of military rule since it gained independence in 1960 from the British, was characterized by poor economic management and a decline in public institutions. Civilian administrations have thus not made much progress in their capacity to handle increasing political demands, which ostensibly had given opportunities to the frequent military incursions in the past. Most economic and social programs are heavily influenced by political decisions which often are not based on evidence. Regrettably, choice of political leaders by the citizens are often not made on the basis of previously affirmed ideologies but on trivialities such as ethnicity and religion. This makes the establishment of a clear social contract between the leaders and the led a dream yet to be realized. As a mixed economic and emerging market, Nigeria has abundant reserve of natural resources and is rated the largest economy in Africa by GDP in 2014. The projected population in 2011 was 164,294,516 on an annual growth rate of 2.9% and life expectancy at birth of 58 years. About 3% of the population are above the age of 65 years. Development of formal healthcare. The emergence of formal healthcare services. The national and subnational development plans dating back to the colonial era. Before contact with the early European explorers and missionaries, traditional medical practices such as the herbalists, local midwives, bone setters, and other esoteric practices were dominant. Earliest form of modern medical services in Nigeria was introduced by the various European explorers, but this was not accessible to the locals until the coming of the church missionaries. The establishment in 1880 of a dispensary in Obosi by the Christian Missionary Society was the beginning of the chronicle of earliest established health facilities in the country. The Sacred Heart Hospital in Abeokuta was built in 1885 by the Roman Catholic Mission, was however the first hospital established in the country. The first government-built hospital for civilians was the St. Margaret's Hospital, built in Calabar in 1889. So, National Development Plans, page 555. Okay, so you have First Colonial Development Plan 1945 to 1955. Second Colonial Development Plan 1956 to 1962. First National Development Plan 1962 to 1968. Second National Development Plan 1970 to 1975. Third National Development Plan 1975 to 1980. Fourth National Development Plan 1981 to 1985. Besides the various national development plans, the country had witnessed several developmental policies and strategies, with each successive political administration producing a development strategies, policy somersault, and then, so that's that. Then another point to note is policy somersault. Another point to note is most economic and developmental programs are direct consequences of political decisions. Another point to note, the overarching blueprint for the greater part of the millennium appears to be the Vision 2020 aim to position the country as one of the 20 largest economies in the world by the year 2020. The main thematic foci of this broad vision are power, transport, oil/gas, and housing/water resources, health and education were captured under human capital and social development. Break of the millennium. Reported state of the Nigerian health system at the turn of the millennium. 1. A weak national health system. 2. Main burden of diseases were attributable to preventive causes and poverty. 3. High maternal, under 5, and infant mortality. 4. Limited capacity for policy formulation, implementation, and evaluation. 5. Non-existence of the National Health Act to give impetus and define the roles of the various tiers of government. 6. Consumer loss of confidence in existing primary healthcare services. 7. Poor state of the secondary and tertiary health institutions. Federal Ministry of Health, 2004. Okay, so still going on. Poor state of the secondary and tertiary health institutions. Non-functional referral services among the various types of health facilities. Poor regulation and distribution of pharmaceuticals and medical supplies. Non-existence of a broad-based financing strategy. Ineffective public-private partnerships for health. Ineffective and inefficient management of scarce health resources. Culture of corruption. Poor consumer awareness of rights to quality health care. Poor coordination of donor and development partners' activities. This situation led to the revision of previous health policy aligned with the current national, regional, and global development strategies such as National Economic Empowerment and Development Strategy (NEEDS), the New Partnership for Africa's Development (NEPAD), and the United Nations Millennium Development Goals (MDGs). This revised health policy of 2004 as an advocacy document recognized traditional medical practice and the role of the National Council on Health and other stewardship organs for the health system. To further advance the development of the country's health system, National Strategic Health Development Plan was crafted from the health sector. To further advance the development of the country's health system, the National Strategic Health Development Plan was crafted from the health sector components of existing national development plans, especially NEEDS and the Vision 2020. 2020. The plan, which covered the period from 2010 to 2015, was approved in March 2010 by the 53rd National Council on Health and aimed to significantly improve the health status of Nigerians through a strengthened and sustainable healthcare delivery system for the period 2010 to 2015. Conceptual model of a health system which recognizes the stewardship, resource generation, financing and service delivery components that should be effectively and efficiently managed by the stakeholders within the system. Stewardship and governance. Key in any health system is the responsibility for the management of the system, which ultimately lies squarely in the domain of the tiers of government existing in Nigeria. The government at all levels discharges this responsibility through the various health ministries, parastatals, boards and agencies at the federal and state levels, while the LG through their health authorities. Headship of these stewardship organs or political appointments. The ministries as focal points provide leadership and policy direction for all health activities in their domain, coordinate healthcare delivery to the public through the various public health facilities, regulate healthcare practice by private providers and monitor program implementations towards the attainment of local, national and international health targets. Responsibility, page 563, is responsibility sharing between tiers of government in Nigeria, Okpani and Abimbola 2015. Responsibility, tier of government, comments. Okay, so health policy making, regulation, price, quality, quantity, resource generation, planning, budget and resource allocation, service provision, primary care, secondary care, tertiary care, monitoring and evaluation. Okay, so you need to look at it. 563, page 563. Governance structures in the Nigerian health system. Level, stewardship / governance structure for health. At the federal level, the governance structures, you have the Federal Ministry of Health, FMOH, National Primary Healthcare Development Agency, NPHCDA, National Agency for Food and Drug Administration and Control, NAFDAC, Nigeria Center for Disease Control, NCDC, National Health Insurance Authority, NHIA, National Agency for Control of AIDS, NACA, and National Institute for Pharmaceutical Research and Development, NIPRD, National Health Research Ethics Committee, NHREC, Professional Regulatory Councils, Boards of Federal Health Institutions. So, under state level of states, the stewardship / governance structures for health include State Ministry of Health, SMOH, State Primary Healthcare Development Agency / Boards, State Hospitals Management Board, State Board of Tertiary Hospitals. And under the LGA, you have the local government health authorities. Professional regulatory bodies, Medical and Dental Council of Nigeria, MDCN, Nursing and Midwifery Council of Nigeria, NMCN, Medical Rehabilitation Therapists Board, MRTB, Radiographer Registration Board of Nigeria, RRBN, Optometry and Dispensing Opticians Registration Board of Nigeria, Dental Therapists Registration Board of Nigeria, Institute of Public Analysts of Nigeria, Health Record Registration Board of Nigeria, Community Health Practitioner Registration Board of Nigeria, Pharmacy Council of Nigeria, PCN, Institute of Chartered Chemists of Nigeria, Medical Laboratory Scientists of Nigeria. The ministry secure funding for health initiatives, work with donor agencies to facilitate program implementation and ensure transfer of relevant skills. The various boards, agencies, and parastatals assume responsibility for specific mandates within the health service system, like insurance, food and drug administration, management of primary, secondary, and tertiary health delivery services, training, accreditation, licensing and discipline of health professionals are done by the various professional regulatory councils. Training structure for formal HRH in Nigeria. That is human resource for health institution, mix of health staff, basic requirements, award, years of training. You have university, doctors, nurses, laboratory scientists, radiographers, physiotherapists. So you have the basic requirement, then the award after training, then the years of training. University teaching hospitals have community health officers, nurses, midwives, postgraduate fellowship training for doctors. School of Nursing, nurses. School of Midwifery, nurses. School of Health Technology, CHU and SG. Health resource generation. HRH are trained in institutions like universities, doctors, nurses, pharmacists, laboratory scientists, radiographers, physiotherapists, etc. Teaching hospital, specialist doctors, community health officers, CHO, nurses and midwives, school and then schools of nursing and midwifery bracket nurses and midwives, and health technology bracket community health extension workers. Weak local capacity for the manufacture of basic consumables for health. High dependence on imports for major equipment and infrastructure. Nigeria as at 2021 had 44 medical schools 2021, 11 dental schools 2021, 99 schools of nursing basic 2021, 88 schools of midwifery basic/post-basic 2021, 60 schools of post-basic nursing specialties 2021, 38 departments of nursing sciences 2021, 15 community midwifery program 2021, 15 community nursing program 2021, 33 medical laboratory schools, 12 schools of physiotherapy. Health resource generation. HR trained in Nigerian institutions, trained in institutions like universities, doctors, nurses, pharmacists, laboratory scientists, radiographers, physiotherapists, etc., teaching hospital scientific specialists, doctors, community health officers, nurses and midwives, schools of nursing / midwifery bracket nurses, midwives, and health technology bracket community health extension workers. Weak local capacity for the manufacture of basic consumables for health. High dependence on imports for major equipment and infrastructure. Nigeria has 8 schools of radiography, 20 universities training pharmacists, 19 schools of pharmacy technology, 87 schools of health technology, 19 schools of health information management, 13 schools of community health officers, 43 schools of community health extension workers, 4 schools of dental technology, 6 schools of dental therapy, and 6 universities training optometrists. Provision of health services. Effective and efficient provision of health service is cardinal to achieving the goals of a country's health system. Nigeria runs a plural healthcare delivery system with the orthodox bracket public and private, alternative and traditional healthcare delivery operating alongside each other. The various service delivery facilities are differentiated into primary care bracket 88.1%, secondary care 11.7%, and tertiary care 0.2%. About a third of them are privately owned, and there are 2.2 health facilities per 10,000 population as of 2011. Nigeria operates a pluralistic healthcare delivery system with the orthodox bracket public and private and the traditional healthcare delivery operating alongside each other. The public health service is organized into primary, secondary, and tertiary levels. The national health policy ascribed responsibility for the primary to local government, secondary healthcare to states, and tertiary healthcare to federal government. Formal and lay care. Healthcare extends beyond the formal sector, and it is important to know the relationship between formal and lay care. 80% of all care is provided by lay people. Studying lay care will help you understand care-seeking behavior, which is an important determinant of the use of formal services. Incorporating the lay perspective is essential to community participation and a sense of ownership of local health services. Formal and lay care continued, providing information and advice, emotional support, practical assistance in providing health and social care. They are distinguished from formal care because 1. Lay care usually takes place in informal setting, e.g. home. 2. Lay carers usually get no or only an unstructured training. 3. Lay carers are usually not paid. Levels of formal healthcare. Levels of formal healthcare. You have teaching hospital down to general hospital, then CHC, HC. Tertiary is teaching, general hospital, secondary, CHC, comprehensive health center, primary. Support services, COS, CBMS, I didn't get this, public health lab, cancer. Okay, so we can look at it, page 574. Primary level, bracket first contact level with a health center, bracket smaller health centers may be called dispensaries, health stations, health posts, serving a defined community or area, normally several villages, bracket at a single village level, and first there might be some community or auxiliary health workers. A health center carries out health promotion, protective, preventive, simple diagnostic, curative, and rehabilitative activities for ambulant patients, normally has no beds, other than perhaps those needed for emergencies and maternity care. In most instances, it has no physician on the staff, but a physician assistant or nurse assisted by community or auxiliary health workers. The most sophisticated devices at a typical health center may be syringes for immunization, fetal stethoscope, and weight scale for babies. The provision of new generation low technology equipment and training to be defined could lead to major enhancements at this level, building on existing traditional medicine at the village level and enhanced interaction with the secondary level. Types of primary healthcare facilities: Type 1, health post; Type 2, primary health clinic; Type 3, primary health center, MPHC or CHC. This is based on the minimum standard for primary healthcare in Nigeria by National Primary Healthcare Development Agency. Nomenclature of health facilities in Rivers State: MPHC, Model Primary Health Center; CHC, Comprehensive Health Center; PHC, Primary Health Center; HP, Health Post. First referral level. First referral level, normally a district hospital or comprehensive health center that is a recognized referral facility providing a 24-hour intramural medical care which represents a higher level of competence than the source of referral, e.g., health center. It may be very small with just few beds. In most instances, these facilities have very limited human resource capacity, a very limited technology base with very basic laboratory services, and if any, imaging equipment and simple surgery is often done under local anesthesia. This technology needs to be defined so as to enhance the quality of healthcare delivery. A telemedicine facility is required to leverage the skill basis by drawing on secondary level expertise for consultation and training. The local government councils are responsible for the provision of primary healthcare in Nigeria. Emphasis at this primary care level will be on the delivery of both home and facility-based services by well-trained and motivated healthcare providers. The health service centers will be linked to the comprehensive health center to form the district health service, and they both will serve as entry points and primary level of care in the health system. The components of primary health care are delivered in an integrated manner with full community participation and collaboration with related sectors outside the formal health sector. The main output of the services of the health center is the guarantee of child survival, safe motherhood, and a healthy population workforce. In Nigeria, it is the responsibility of the local government councils. Secondary health care. A more sophisticated hospital, usually called general hospitals, and provide multi-specialist intra- and extramural care, and serving as a backstop for the first referral hospitals in the hierarchy of technical competence. It may also, on occasion, have special expertise in some particular medical diagnostic and treatment domain, which will qualify it as an institution of last referral for a specific subject. The technology should allow telemedicine to specialists at the tertiary level. More substantive technology targeted at specific diseases needs to be developed, such as palliative treatment for the late presenting patients with advanced cancer, with lower cost therapeutic and imaging requirements compared with that for curative therapy. Visiting biomedical physicists and engineers to maintain and calibrate equipment. In Nigeria, state governments are responsible for this level. Tertiary healthcare. A most sophisticated hospital located in a national and each state's capital in the federation or other big city, typically established as a multi-specialist hospital like University Teaching Hospital, federal medical centers, and single specialty hospitals like psychiatry, orthopedic, children, etc. hospitals. It provides the highest level of medical care available in the country or a region. This level follows the Western model of centralized expertise and high technology and is a resource for education, training, research, and consultation. Specialists in attendance can monitor and communicate with lower level centers by telemedicine. In Nigeria, 70% of health budget goes to hospitals and tertiary care. In Nigeria, it is the responsibility of the federal government. Identify the various health services in your local government area. Would you consider traditional healers or alternative therapists as formal healthcare providers? Why? In your locality, which members of the family will be most likely to care for an elderly disabled relative? Share your experience about any level of healthcare you have had contact with, either as a patient or a carer. Health facilities in Nigeria 2022. Level of practice, number, percentage. Primary health facilities, you have 33,570, that's constituting 85.1%. Secondary health facilities, you have 5,720, make up 14.5%. Tertiary health facilities, 150, making up 0.4%. In terms of proprietorship, public, 28,981, that is 73.5%. Private, 10,459, 26.5%. Healthcare financing, The Nigerian health system is influenced by the economic principles of all tiers of government, which often exhibit both capitalist or socialist tendencies. In principle, universal access to primary health care delivery delivered by public facilities based on welfare provision is the norm. In practice, because demand outstrips supply in public domain, consumers have to bid and pay for it in the private health market, thus making access to basic health services highly inequitable and often fragmented. Out-of-pocket payments for health services constitutes about 62% of healthcare financing in Nigeria. The National Health Insurance Scheme was created since 1999 and have enrolled only 3% of the population, mainly federal civil servants, with less than 2% of women aged 15 to 49 years being insured. Pattern of financing and provision: revenue, government, private. Pooling: revenue source, pooling, government pool, private no pool. Under revenue source: purchasing, you have NP, and under government you have N, you have P. Then under private you have out of pocket. Under revenue source you have provision, government, public, private, public, private. Okay, so that's that. National Health Insurance Scheme, page 585. Okay, so the National Health Insurance Scheme was first established under Act 35 of 1999 by the federal government of Nigeria. It is aimed at providing easy access to healthcare for all Nigerians at an affordable cost through various prepayment systems. The scheme was officially launched on 6th of June 2005, and commencement of services to enrollees started in September 2005. Formal sector: the formal sector of social health insurance program is a social health security system in which the healthcare of employees in the formal sector is paid for from funds created by pooling the contributions of employees and employers. The formal sector consists of the following: 1. Public sector. 2. Organized private sector. 3. Armed forces, police and allied services. 4. Students of tertiary institutions. And 5. Voluntary contributors. Guideline for public sector and organized private sector. Membership: employees of the public and private organized private sector employing 10 or more persons shall participate in the program. Contributions are earnings related. The employer pays 10%, while the employee pays 5%, representing 15% of the employee's basic salary. Employer may pay the entire contribution or undertake extra contributions for additional cover to the benefit package. Waiting period: there is a processing waiting period of 60 days before a participant can access services. Scope of coverage. Guidelines continue. Scope of coverage: the contributions paid cover the healthcare benefits for the employee, a spouse, and 4 biological children below the age of 18 years. More dependents or a child above the age of 18 will be covered on the payment of additional contributions from the principal beneficiary. However, children above 18 years who are in tertiary institutions will be covered under the tertiary insurance scheme. Benefit package: out-of-patient care including necessary consumables, prescribed drugs, pharmaceutical care and diagnostic tests as contained in the National Essential Drugs List and Diagnostic Tests List. Maternity care for up to 4 live births for every insured contributor couple in the formal sector program. Preventive care including immunization as it applies in the National Program on Immunization, Health Education, Family Planning, Antenatal and Postnatal Care. Consultation with specialists such as physicians, pediatricians, obstetricians, gynecologists, general surgeons, orthopedic surgeons, ENT surgeons, dental surgeons, radiologists, psychiatrists, ophthalmologists, physiotherapists, etc. Hospital care in a standard way for a stay limited to a cumulative 15 days per year. Then, after the beneficiary and or employer pays, the primary provider shall pay per diem for bed space for a total 15 days cumulative per year. Eye examination and care excluding the provision of spectacle and contact lenses. A range of prostheses limited to artificial limbs produced in Nigeria, and preventive dental care and pain relief including consultation, dental health education, amalgam filling and simple extraction. Note: all providers are expected to provide counseling as an integral part of quality care. Other NHIS programs. Other programs under NHIS include 1. Urban Self-Employed Social Health Insurance Scheme, USHIP. 2. Rural Community Social Health Program, RC-SHIP. 3. Children under 5 Social Health Insurance Program. 4. Permanently Disabled Persons Social Health Insurance Program. 5. Prison Inmates Social Health Insurance Program. 6. Tertiary Institution Social Health Insurance Program, TSHIP. 7. Voluntary Participant Social Health Insurance Program, VPSHIP. 8. Armed Forces, Police, and other uniformed services social health insurance program. 9. Diaspora Family and Friends program. 10. International Travel Health Insurance program. Recent innovations in health insurance and coverage in Nigeria. National Health Insurance Authority Act. Act establishes National Health Insurance Authority, NHIA, or the authority, overseen by a governing council. The governing council consisting of chairman, DG of NHIA, which acts as the secretary, one representative from the 6 political zones, 2 representatives of the organized labor, 1 representative of a civil society organization, and 1 representative from the Federal Ministry of Health, Federal Ministry of Finance, Nigerian Employers Consultative Association, NECA, and the Armed Forces, respectively. Objectives: promotion, regulation, and integration of health insurance schemes, improving and improving and harnessing private sector participation in the provision of healthcare services, and 3, assisting the authority in achieving universal health coverage for all Nigerians. Functions: the authority shall, among its other functions, 1. Secure mandatory health insurance for every Nigerian and legal resident. 2. Establish a basic minimum package of health service across all health insurance providers in the country. 3. Provide general guidelines for the implementation and utilization of the Basic Healthcare Provision Fund, BHCPF. 4. Regulate the activities of health care facilities, health maintenance organizations, HMOs, mutual health associations, MHAs, and third-party administrators. State health insurance scheme. Section 13 of the Act provides for states of the Federation and the Federal Capital Territory to establish and implement a state health insurance and contributory scheme for the purpose of providing access to health services to all its residents. The Act defines residents to include employers and employees in the private and public sectors with 5 employees and above, informal sector employees, and other residents of Nigeria. The scope of the coverage for the health insurance and contributory scheme shall be the minimum prescribed in the Basic Minimum Package of the National Health Act 2014. Every person resident in Nigeria is required under Section 14 of the Act to obtain health insurance. Establishment of similar schemes for employees of federal MDAs. Individual complementary subscription to private insurance schemes. NHIA and BHCPF. From Section 24 of the Act, NHIA will 1. Provide basic minimum healthcare package for the BHCPF, that is Basic Healthcare Provision Fund. 2. Make regulations on accreditation, quality of care, and complaints handling. 3. Collaborate with state health schemes and state-owned institutions to accredit and enlist primary and secondary healthcare facilities in line with the criteria stated in the relevant regulations. 4. Help provide for the administration of an ombudsman to handle enrollees' complaints. Vulnerable Group Fund, VGF. Section 25 of the Act. Vulnerable Group Fund, VGF. Section 25 of the Act provides for the establishment of the VGF to subsidize the cost of providing healthcare services to vulnerable persons in Nigeria. Vulnerable group include 1. Children under 5. 2. Pregnant women. 3. The aged. 4. Physically and mentally challenged. And 5. The indigent, as may be defined from time to time. Funding the Vulnerable Group Fund. BHCPF 1. 2. Health insurance levy. 3. Telecommunications tax. 4. Government allocation. 5. Investments made by the Governing Council. And 6. Grants, donations, gifts, and any other voluntary contributions made to the VGF. HMOs, MHAs, third-party administrators. The NHIA is empowered by the Act to accredit HMOs, MHAs, and third-party administrators to perform functions outlined in the Act, including collection and prompt remittance of contributions. Such accreditation shall be in a manner determined by the operational guidelines of the authority and can be withdrawn upon breach of the provisions of the operational guideline. Basic statistics on Nigeria, World Health Statistics 2020. Where are we now? Basic statistics, parameter estimate. Total population 220,103,977. Life expectancy at birth 55.2 years, 54.7 years for males and 55.7 years for females. Health life expectancy at birth 48.9 years, 48.7 years for males and 49.2 years for females. Maternal mortality ratio 2017 estimate 917 out of 100,000 live births in 100,000 live births. Under 5 mortality 120 per 1,000 live births. Neonatal mortality 36 per 1,000 live births. Prevalence, epidemiology, prevalence, parameter estimates. Prevalence of stunting in under 5 children, 36.8%. Prevalence of wasting in under 5 children, 6.8%. Prevalence of overweight in under 5 children, 2.1%. Okay, so that page 602 continued. Prevalence of overweight in under 5 children, 2.1%. Prevalence of anemia in women of reproductive age 15 to 49 years, 49.8%. Parameter estimates. New HIV infections, 0.65 per 1,000 uninfected population. Tuberculosis incidence, 219 per 100,000 population. Malaria incidence, 291.9 per 100,000 population at risk. Probability of dying from any of CVD, cancer, diabetes, chronic renal disease between CVD is cardiovascular disease, cancer, diabetes, chronic renal disease between 30 and 80 years, 22.5%. Suicide mortality rate, 9.5 per 100,000 population. Proportion of women of reproductive age with met needs for modern family planning, 35.6%. Proportion of population using safely managed drinking water services, 20%. Proportion of population using safely managed sanitation services, 27%. Proportion of population using a hand washing facility with soap and water, 42%. Proportion of population with primary reliance on clean fuels and technologies, 10%. Annual mean concentration of fine particulate matter PM2.5 in urban areas, 46.3 picogram per meter cube. Age standardized raised BP among persons 18 plus, SBP of 140 mm mercury and DBP, that is systolic blood pressure and diastolic blood pressure, 140 mm mercury, 90 mm mercury, 23.9. Prevalence of obesity among children and adolescents 5 to 19 years, 1.9%. Age standardized prevalence of obesity among adults greater than 18 years, 8.9%. So these are just figures. You need to just look at UHC service coverage index 42. Okay, so page 606. Demographic and socioeconomic situation. Parameter frequency, that is for Afro. You have annual growth rate 2.5%. Crude birth rate per 1,000 population 39.9. So these are page 606. Crude death rates, total fertility rates, population living on less than $1, PPPs, INC, gross national income per capita. Healthcare financing, 607. Universal health coverage, service coverage index. So this page 207, just some figures attached to it. Health workforce, CADA number, density per 10,000 population. Physician, 55,376 bracket 118,621. Density per 10,000 population, 4 bracket 2.2. Nurses and midwife, dentistry, pharmacists, community health workers, environmental and public health workers, psychiatrists. Okay. Density of medical doctors, 3.8 per 10,000 population. Density of nursing and midwifery personnel. Density of dentists. Density of pharmacists. Coverage of essential health services, UNICEF 2019. Demand for family planning satisfied by modern methods in women aged 15 to 49 years, 43%. So page 610, page 611, still all those statistics. Nigeria's progress has also been slower than expected when compared to targets and comparable countries. Nigeria is still far from reaching its national target for MCH, maternal mortality, deaths per 100,000 live births. So you can look at it, page 612. Maternal mortality reduction, percentage reduction, 2004 to 2008. Rwanda had the highest, 35%, followed by Uganda, Ethiopia, Tanzania, Ghana, 17%, and final or list on the table is Nigeria, 14%. Page 613, trends in investment and outcomes. Okay, so that page 613, trends in investments and outcomes. So You have per capita health expend in Nigeria 2000 to 2019, percentage of GDP spent on health in Nigeria 2000 to 2019, maternal deaths per 100,000 live births 2000 to 2017, trend in life expectancy at birth 1999 to 2023. Comparison of similar health systems. So we're comparing Nigeria, Ghana, Kenya, Egypt, Zambia. Indicator year of estimation and different parameters are being compared. Challenges with HSS and R in Nigeria. Health is not a political priority. Inefficient flow and management of financial resources. High incidence of out-of-pocket payment. Poor design of health budgets. Complexity of the health system. Status of national health insurance. Status of national health insurance. Low absorptive capacity of current governance structure. Inadequate financing, budget and other sources. Misaligned roles/priorities of donor/implementing agencies. Absence of appropriate accountability framework and strategies. Poor capacity and weak mechanism to tap the great potentials from the private sector. HSS, stakeholders, context and dynamics. Stakeholders' expectations. 1. Accountability. 2. Better results. 3. Higher quality. 4. Greater efficiency. 5. Greater number of people served. 6. Equity. 7. Affordability. 8. Coverage. Context and dynamics. 1. Health reforms. 2. Decentralization. 3. Increasing costs. 4. Decreasing resources. 5. Increasing changing demand. 6. Increasing poverty. 7. Technical innovation. 8. Multiple initiatives. Transitions in human development. 1. Epidemiologic. 2. Demographic. 3. Economic. 4. Behavioral. 5. Healthcare system. 6. Political. Under epidemiologic, you have disease, infective, communicable to chronic, non-communicable. Demographic, under that you have increasing population, younger to older population, rural to urban. Under economic, you have developing to developed economies. You have modern technologies leads to increasing exposure to environmental risk factors, e.g. air pollution. Under behavioral, you have changing lifestyle. Under that, you have faulty diet, alcohol, sedentary lifestyle, obesity, stress. Under healthcare systems, you have centralized to decentralized, then cost containment. Under political, you have controlled to free market economies. Former British Prime Minister Tony Blair wrote that success will go to those companies and countries which are swift to adapt, slow to complain, open and willing to change. Health System Strengthening/Reform, HSR. HSS is an array of initiatives that improves one or more of the functions of the health system and that leads to better health through improvements in access, coverage, quality, or efficiency, WHO. HSR is an ongoing process of sustained, purposeful, and strategic change in policy and institutional arrangements in the health sector designed to improve the performance of the health sector and ultimately the health status of the population. Goals of HSS and R. 1. Universal health coverage is unrestricted access to quality and effective health services. 2. Resilient health system. That is the ability of the health system to absorb disturbances and respond to current and emerging trends. 3. Universal health security, which comprises of 1. Individual health security entails which comprises individual health security and then collective health security. Individual health security entails protection against risk through improved knowledge and social protection. Collective health security involves reducing the vulnerability of societies to health threats that spread across national borders. Security is valued by individuals, families, states, and other actors. Health security strongly linked to national security. A major global political agenda due to 1. Global health-related concerns and pandemics, e.g. Ebola, Zika, COVID-19. 2. Antimicrobial resistance, which is a fundamental threat to human health, development, and security, WHO. 3. Rise in non-communicable diseases, the silent pandemic. HSS, arrow, national health security, arrow, prosperity. We strive to strengthen our local system so we can achieve universal health coverage, health security, and a resilient health system. So this is a diagram. We have strengthening health security and health systems. UHC, health security, resilient health systems. So health security, you see the components. Okay, so look at this page 621. Key considerations in HSS. 1. Scope. Include all building blocks, covers local health needs. 2. Scale. National and across levels of the system. 3. Sustainability. Sustained over time and tackle systemic problems. 4. Effects. Improved health outcomes, quality, equity, financial risk protection, responsiveness. Key areas of health sector reforms: WHO. 1. Reducing. 2. Organizing. 3. Integrating. 4. Pursuing. 5. Increasing. Reducing exclusion and social disparities in health by universal coverage reforms. 2. Organizing health services around people's needs and expectations by service delivery reforms. Integrating health into all sectors by public policy reforms. D. Pursuing collaborative models of policy dialogue leadership reforms. For integrating health into all, okay, that is, we've talked about the public policy reforms. Pursuing collaborative models of policy dialogue leadership reforms. And finally, increasing stakeholder participation. Universal coverage. This will ensure that health system contribute to equity, social justice, and end exclusion by moving towards universal access and social health protection. Issues with access: geographic, socio-organizational, financial, range of services. These are defined by availability, accessibility, accommodation, affordability, acceptability. Service delivery reform: reorganizing health services around people's needs and expectations to make them socially relevant and more responsive to the changing world while producing better outcomes. Issues: fragmentation, poor linkages, motivation. Public policy reforms: this aim at securing healthier communities by integrating public health actions with primary care, by pursuing public policies across sectors, and by strengthening national and transnational public health interventions. Leadership reforms: this will tend towards replacing disproportionate reliance on command and control on one hand and laissez-faire disengagement of the state on the other hand by the inclusive, participatory, negotiation-based leadership indicated by the complexity of contemporary health systems. National health interventions, policies, strategies, plans, actions in the Fourth Republic. This is page 628. I think this has been mentioned before, yeah. Okay, so I think we might need to look at it again. Olusegun Obasanjo, May 29, 1999. You can look at it later. 1999 to 29th May 2007. So all the things they established: interventions, NHIS, NACA, WHO, World Health System, World Minimum Health Package, first revision of National Health Policy, Health Service Sector Reform Program, launch of formal sector program of NHIS, NHREC, NPI, NPHCDA, Umar Hussein Radwa, 2007 May 29th. Then Goodluck Jonathan, what he did, Muhammad Buhari, the things he did, the program. So page 629. I think we've repeated it before. So intended impact of national interventions across health system building blocks. So the programs and LGHF, I think we've seen this before. HSR programs in Nigeria, basic health service delivery. This is aimed at providing access to quality health care to the underserved. The logistic and supply chain management reforms, as well as the use of technology, were designed to improve coverage and access. HSR programs, preventative health care. This involves the introduction of new vaccines and essential commodities. Clinical governance. Sevicon was revitalized in the FMOH and its parastatals to ensure that patients receive quality health care services. Unlocking the potentials of the private sector. A ministerial committee was set up to facilitate the establishment of world-class specialist hospitals and diagnostic centers in each geopolitical zone. Other HSR programs initiatives include primary healthcare under one roof, PHUCOF. In 2011, bringing PHC under one roof was launched to integrate management of PHC and reduce fragmentation in the delivery of PHC services. Save 1 Million Lives Initiative (SOML), launched in October 2012 as a public-private partnership with a vision to save 1 million lives by the year 2015. Shaw P. Maternal and Child Health Program. This was established in 2012 to reduce the maternal, newborn, and child morbidity through expanded access to skilled birth workers. Midwife Service Scheme (MSS). This program was aimed at reducing maternal mortality by deploying unemployed and retired midwives to selected primary healthcare facilities in rural communities. Establishment of Nigerian Center for Disease Control (NCDC). Mandates. NCDC was established in 2011 in response to the challenges of public health emergencies and to enhance Nigeria's preparedness and response to epidemics through prevention, detection, and control of communicable diseases. Vision: to reduce mortality and morbidity resulting from disease of public health importance and therefore enhance the economic development of Nigeria. Achievement: development of National Action Plan for Health Security 2018 to 2022. Private sector involvement in the health sector. Nigerian Private Sector Health Alliance was set up to mobilize private sector health resources, driven by the private sector's potential to expand access to health services, improve quality of care, and complement the public sector's efforts in addressing health system challenges in the country. Aim is to mobilize the broader business and corporate community as well as the private health sector towards a multi-sectoral coalition to improving health outcomes. Establishment of Basic Health Care Provision Fund to be used for 1. Provision of a basic minimum package of health services through the NHIS. 2. Provision of essential drugs and improved health facilities. 3. Development of human resource for health. Nigeria's performance across UHC indicators. Indicator standards. Okay, so continue from page 641. Nigeria's performance across UHC indicators. Indicator standards. Nigeria status. So I think we may need to look at this later. Emerging consensus on financing for UHC. Market-driven privately financed health system. Governments must force the healthy wealthy to cross-subsidize the sick and the poor. User fees are the worst way to finance health services and should be reduced to the barest minimum. Private voluntary insurance, including community-based insurance, is ineffective, inefficient, and inequitable. Community-based insurance. Okay. Public finance (tax financing and social insurance) is the key to universal health coverage. Policy options for achieving universal health coverage, page 643. So public expenditure on health, extend to uninsured, reduce cost sharing, include other services. Height: what proportion of cost is covered? Cost for occupational health care, employment, injury, benefits. Breadth: who is covered? Informal sector, MSEs, farmers, migrants. Depth: which interventions are provided? Primary prevention, clinical care, promotion. From theory to practice, how do we attain resilience, universal coverage, and health security through HSS in Nigeria? As through health system strengthening. Change. Convincing human beings to give up something they know for something new and uncertain is not Tea Party. Leading such fundamental change requires 1. Visionary leadership. 2. A strong commitment to transparency. 3. Ensuring stakeholders have a voice in the process. 4. Making listening and communication a personal priority. 5. Developing a motivating narrative. Determination of the long-term goals and objectives of an enterprise, adoption of courses of action, and the allocation of resources necessary for those goals. Chanda, 1962. Strategy: the direction and scope of an organization over the long term, which achieves advantage for the organization through its configuration of resources within a changing environment to meet the needs of the markets and to fulfill stakeholder expectations. Johnson, Scholes, and Whittington, 2011. Effective strategies comprise of 1. Prescriptive elements, show what to do. 2. Descriptive elements, show how to do it. Key questions in strategic thinking: where are we now? That is, under that we have strategic analysis, going to strategic choices, then strategy implementation. Strategic choices is where should we be. Strategy implementation, how will we get there? What to do, how to do it. Get right leadership under what to do, under how to do it. 1. Right people in right places. 2. Merit-based selection of heads of MDAs and health facilities, visionary leaders with adaptive leadership skills. What to do? Number 2, strengthen governance. How to do it? 1. System redesign for effectiveness. 2. Strengthen intersectoral collaboration. 3. Stakeholder management bracket. Annual health summit. 4. Strengthen reward system. 5. Develop accountability framework for MDAs. 6. Decentralize administration to what, LGAs. What to do? Number 3, regulation. How to do it? Liberalization, deregulation, privatization. Number 4, what to do? Innovative financing. How to do it? 1. Increase public financing, BHCPA, PF, syntax, state. 2. Expand social insurance to informal sector, state, OPS, unemployed. 3. Provide full coverage for vulnerable population, like children, elderly, unemployed, underemployed, and people with special conditions, pregnancy, LTMC, emergency care. Number 4, improve management of financial resources. Number 5, increase GGHE from 6.6 to 15%. Number 9, reduce OOP from 75% to 30%. Increase GGHE from 6.6 to 15%. Reduce OOP, that is out of pocket, from 7.5 to 30%. Strengthen workforce. Under what to do? How to do it? Establish HR departments in MDAs. 2. Develop national/state health workforce account. 3. Develop technologically skilled healthcare workers. What to do? Next point is provision of critical commodities. How to do it? 1. Create enabling environment for the private sector. Capital, tax, incentives, energy. Establish supply and logistics departments in MDAs. Strategic options. What to do? How to do it? What to do? Next point is improve service. How to do it? 1. Pursue UHC, resilience, equity, efficiency. 2. Quality, accreditation, audit, CG. 3. Engineering/environmental redesign of hospitals. 4. Patient appointment system. 5. Flexible and individualized patient care plan, right treatment to the right person at the right time. 6. Isolation facilities in all secondary and tertiary facilities. What to do? Next point, strengthen research. How to do it? 1. Strengthen planning, research and statistics department. 2. Develop national and state research agenda. 3. Budget and release of research funds. Evidence-based, next point 4. Evidence-based decision making at all levels. 5. Support evidence synthesis and translational research. 6. Partner with academic institutions for periodic needs assessment and priority setting. Strategic option. What to do? Next point, behaviors. How to do it? 1. Strengthen individual, collective, and global health security, media sensitization, risk communication. 2. Behavior change of HCW, healthcare workers, promptness, courtesy, communication, hand hygiene, use of PPE. Next point, what to do? Technological innovation. Under how to do it, ICT, EHR, that is electronic health records, M-health, telemedicine, IoT, Internet of Things. What to do? Next point, partnership for health. How to do it? 1. Strengthen partnerships for health, tiers of government, non-governmental agencies, private sector, communities and individuals. Explore legislative backing explore legislative backing for responsibilities among stakeholders to enhance accountability, coordination, and efficiency. Increase the capacity, responsibility, and revenue to states and LGA for provision of comprehensive health care to the populace. Lessons from the past. What brought us here can't take us there. Governance/stewardship in health is too serious a business to be left alone to the politicians, and so the business of developing our health system is too serious a matter to be decided or controlled by politicians. Policy instability in last 2 decades. So, from Ibrahim Babangida to present currently, SAP. Babangida is SAP. SAP, Structural Adjustment Program. Next, Abacha is Vision 2010. Obasanjo is the Kuru Declaration. Obasanjo is NEET. Yar'Adua is 7-point agenda. Good Luck is Transformation Agenda. Then currently, Vision 2020. Vision 2020. So So Vision 2020. Thematic areas under physical infrastructure are limited to 1. Power, 2. Transport, 3. Oil and gas, 4. Housing and water resources. These were identified as major challenges constraining economic growth and development in Nigeria. Health and education were categorized under human capital and social development. National health policy. Goal was to establish a comprehensive healthcare system based on primary healthcare that is promotive, preventive, restorative, and rehabilitative to every citizen of the country. National Strategic Health Development Plan. Priority pillars were placed on leadership and governance for health, health service delivery, human resources for health, financing for health, national health management, information system, partnership for health, community partnership, participation and ownership, research for health, world minimum healthcare package. Then you have integrated management of neonatal, childhood and maternal illnesses. Okay, so we are stopping here, page 650, slide 654. So we're going to continue next with slide 655, options for improving investment in the health sector.